Just to reintroduce myself, my name is Jim Frame. I'm the medical director for PERCOM. And what we're going to do is part 2 of respiratory emergencies. Last time I spoke, I wanted to tell you a little bit about the respiratory emergencies and how they appear on the National Registry exam. They're virtually all scenario-based. And so you're going to be given a case of a 17-year-old who's having a lot of asthma attack. The scenario question that I read that I saw in the last version 3, was a 17-year-old girl who was having an asthma attack. She'd taken 4 albuterol aerosols with Atrovent throughout the day, has not improved. She has no steroids. She's been intubated once, admitted to the ICU twice, and this is her presentation. She's got a respiratory rate of 40. She's got cyanosis around her lips, pulse oximetry 85% on just after her last aerosol, and of course a tachycardia rate of about 140. These children or teenagers are at high risk for sudden death. The fact that they've been in the ICU before and intubated once before means that they have a severe asthma. And subsequently, when you take your sample histories and you see that a patient's asthmatic, first thing you ask is, how many aerosols did you take? Are you on steroids? And then you roll into the, been admitted for your asthma before? Have you been intubated? You've been in ICU and such. So these are all very pertinent questions. And on the scenario base, which is about 4 questions based on that scenario, one of them is going to be, which of the following are high-risk characteristics? And so you're going to just go down the list: admission to the hospital, ICU admissions, or intubations. Those are probably the best risk factors that you can have when it comes to answering that question. If they say a patient's been in the emergency room 5 or 6 times, discharged to home, been to urgent care, been to the doctor's office and such, patient uses an inhaler and it usually relieves her asthma, but in this particular case it didn't. So that's your scenario that you're going to see on the National Registry. Now, when we talk about patients who have had 3, 4, or 5 aerosols within a day, you have to ask, did you get any better? How far apart were they spaced and such? Well, she waited about 10, 15, 20 minutes. Doctor says not to do it for every 2 to 3 hours, but we couldn't take a chance anymore. And this is her 4th aerosol. It's usually when they're after 3, and 3 is the magic number of aerosols that you give at home, and the patient continues to wheeze, it's status asthmaticus. So it's going to be more than 3 aerosols. And the patient has not had a break in between of a significant improvement, if you will. Now, contrast this for a moment with status epilepticus. Patient has a seizure, stops, has a prolonged recovery phase, what we call postictal, where they just are lethargic. They're just laying there. They may or may not be grumbling, but they're certainly not speaking to you. If they're talking to you, I question the diagnosis of a seizure. But in this particular case, talking about asthmatics, if they have no improvement in between aerosols and they roll right back in the next one, then right back in the next one, they call you because they've exhausted their 3 aerosols at home. You may get on the scene and start treating for status asthmaticus. When you auscultate these patients, they are wheezing in all fields, no rales, no rhonchi. If they do have rhonchi and a fever, they've got a pneumonia on top of the asthma attack, and subsequently, once again, they're high risk. Now, the other follow-on questions on the National Registry, and again, there's 4 of them, all based out of one scenario, is going to be the 17-year-old person who has had 3 aerosols at home, no improvement, no getting better in between the aerosols. So you arrive on the scene, and first thing you do is you see their pulse ox is 85%. You see they're tacking at 140, and they got a respiratory rate of 40. Badness is about to happen. So ketamine would be a great choice. First of all, you preserve the patient's breathing and gag reflex. Second is, ketamine has been shown to actually relax the bronchioles and improves asthmatics. So ketamine would be the drug of choice that I would use for this intubation. But certainly you have to consider at this point intubation. Status asthmaticus, especially with a silent chest or barely wheezing, yet they're only speaking 1 to 2 words per sentence, is problematic. Lastly, when we, yes, ketamine, I was a little slow on my finger here. It does have bronchodilation, and I think it's the favored medication. We certainly use it in the emergency department when we get status asthmaticus on these patients. And I even use it for COPDers because even though they don't have much bronchodilation capability, they've got some, especially in the upper airways, because emphysema has destroyed the lower airways and probably even in the mid-chest. They got the barrel chest. But somewhere up here in the upper parts of their lungs, they may certainly still have normal lungs. And so can you bronchodilate a normal airway? The answer is yes. You can always make it a little bigger. And sometimes just a 1/4 increase in the diameter can increase airflow by 16 times. Now, we're only talking about small areas here, but significant enough to keep pulse oximetry at least in the 90 percentile for COPDers. Asthmatics, it's a functional disease. They're not showing any destruction of their lung. You should be able to bronchodilate the entire lung on both sides. This is where ketamine helps. Obviously, if you're doing ketamine, you're tubing the patient. You just can't give the ketamine and wait to see if they get any better because they're not. So they'll require intubation. Okay, now let's just talk a little demographics for a second. One of the questions on the exam, the reason why I threw in this slide is because one of the questions did indeed address this. And it was possible reasons for worsening asthma. And the 5 that I listed here appeared on version 2, version 3 in different formats. The wording, not quite exact, but it's very, very close as far as the symptoms due to alternative conditions, upper airway disease, cardiac failure, or even a lack of fitness. These are all comorbidities, if you would. They're ways to exacerbate asthma, yet not in the traditional sense. The virus gets into the lungs, causes mucus production. In the older patient who's got congestive heart failure, fluid gets in the lung. And if you've ever heard the term cardiac asthma, it's congestive heart failure, water in the lung that's causing them to wheeze. That's why we call it cardiac asthma. It's an older term. You may run into it in some books. You may hear some other people talk about cardiac asthma, but that's what it is. It's wheezing in the setting of CHF. And then, of course, there's a lack of fitness. Person goes outside, starts to work a little bit, hasn't worked out in so many years. And within the first 5 minutes or so, they get real short of breath, difficulty breathing. Well, lack of fitness as well. So when we got a person who's, as far as comorbidities are concerned, rhinosinusitis, infection in the sinuses, infection in the nose, gastroesophageal reflux. You'll see that a lot, especially with newborns. In the neonatal nursery, we'll run into occasional children who are on Zantac. You may even get called to the scene of a little 2 or 3 month old who's wheezing quite a bit. And when you go through their medication list, you'll find that there's going to be albuterol, there's going to be some breathing machines, whether it's Zopanex or albuterol that they're using, but you may run into the occasional child who's on Zantac. And it's the only one that we've got approved for neonatal gastroesophageal reflux. But reflux itself, the burning itself going up the esophagus, or the aspiration of that real bad tasty stuff that you get in your mouth once in a while when you don't recognize it, it's stomach acid. In an asthmatic, that can actually stimulate an asthma attack. So you'll be looking for people who are on Zantac, especially the little babies. And then, of course, OSA, obstructive sleep apnea, can worsen a patient's condition as well, just by the fact that they can't get their diaphragm pushed down because there's a whole lot of stomach there that inhibits the diaphragm from contracting, pulling down, and as a result, opening up the lungs. Just not happening. it's called obstructive sleep apnea, but back in the day, these patients were referred to as Pickwickian. Pickwickian syndrome being a big, massive obesity inhibiting breathing. And it's got some theological and actually theatrical history, if you will. Look up Pickwickian syndrome if you're on Wikipedia one day and just kind of go through it. You'll be amused. All right, and then lastly, you get patients who are sensitized with an irritant in a home or a work environment. I had this happen to me when I was a fireman, where I was in a basement. This was back in the 70s, and the refrigerators had just made a transition from ammonia to Freon. It was safer. We were moving an old refrigerator out because there was a smell, a strong odor of smoke in there. So we opened up the refrigerator, closed it, and we started lifting it up. And when we did, the ammonia leaked a bit. And when it did, it got into my lungs and caused an irritation of unbelievable proportions. I actually walked out of the home and went right to the ambulance and got a shot of 0.3 epi. And I was done for the day. It was incredible what ammonia can do. It can lock up a normal person's lungs in a heartbeat. So watch for the person who, in their brilliance, decides that, geez, I'm going to clean with ammonia, and oh, by the way, I'm going to clean with bleach. Hey, how about if I just mix them together in a bucket and clean? And so they mix it together in a bucket, these little fumes come out, and then they start the mop, and all of a sudden they're choking and gagging. So watch for the normal person who's wheezing, and then ask them about their home remedy chemistry that they were trying to perform. Okay. As far as the asthma is concerned, albuterol aerosol with atropine, you throw 3 doses into the reservoir, you put them on a face mask, you start an IV, you give them their Medrol, you let them inhale as much as they can through a mask, and just leave them alone and let them breathe. If they start to crash, or if they become what they call status asthmaticus, as we've discussed, if they're getting confused, they're not improving, they're still talking 1 word per sentence, they're actually getting very restless and kicking, and they may, at this point, be so hypoxic that they're slapping the mask away. You put on a pulse oximetry, maybe 92, 93%, say, geez, you know, is this person going wacky or something on you? And the answer is no. They could very well be in CO2 narcosis. Their CO2 could be in the 60s or 70s and such. And for a young person, they get narcotic feeling. They get either restless or they start getting somnolent. And these are real trigger signs for you to be proactive in intubation, or you're going to lose these patients. Remember, the number 1 cause of asthma death is that the patient and the family underestimate the severity of the attack. But the number 2 cause is that the doctor, the EMS provider, or whoever, whatever healthcare provider has responded to this patient, number 2 cause of death is that they underestimate the seriousness of the attack. I could walk into a room in the emergency department and see, you know, 17-year-old sitting there and going, okay, well, you know, I'm going to give her a little bit of time, listen to her. Nah, she's not wheezing much. Yeah, she's been intubated before, you know, no problem. Look at the pulse ox 86. You're going to wait for it to come up. All right, call me if any problems. You know, next thing you know, they're calling you in there because she stopped breathing. And once the breathing stops, once the heart stops, it's very, very difficult to get them back. I prefer intervention, not reactive, and not management by crisis. When you see these patients, get them tubed. I emphasize that now in the clinical world, but I also emphasize it for the National Registry exam. When you're presented with a severe asthmatic, ketamine and tube them. Airway management, bingo, number 1. Okay, I just gave you 4 questions off the National Registry. You guys should do good in respiratory emergencies. All right, we're gonna move on. Community-acquired pneumonia. Community-acquired pneumonia is just that. It's a person who gets pneumonia, not associated with being in the hospital within the last 30 days, or a pneumonia where the patient's living in a nursing home. These are nursing home or healthcare associated pneumonias, what they call HCAPs. And the person who's been in the hospital within the last 30 days and come out. These are hospital-acquired pneumonias, HAPs. Big difference between the two, because if you come out of the hospital, if you've been in the hospital the last 30 days, you've got one type of bug that's most common, a common bacteria. In the nursing home, you've got another type of bacteria that's very common. And out in the world where you and I live, if you catch pneumonia from being out there, that still is yet another type of bacteria that's the number one cause. So in your sample history, running fever, cough, congestion, shortness of breath, difficult to breathe, and a patient may have a history of COPD or asthma or chronic bronchitis, and they've piled a pneumonia on top of it. Really makes for a bad day for the asthmatics and COPDers. So in your sample history, have you been in the hospital the last 30 days? No. Obviously, they're not living in a nursing home, you didn't respond there. What you should know about pneumonia is that it's the 5th leading cause of death in the country, has been for a number of years. It dipped down into 6 one year, but then bounced back up into 5. Personally, when you're right behind heart attacks, strokes, diabetes, and all the other happy stuff that's out there, being the 5th cause of death is pretty rough. Consider that 2 to 2.4 million people per year die in the United States. That's a pretty high number. So it's the 5th leading States. The morbidity and mortality associated with it are common in elderly patients, anybody who's caught influenza, and immunocompromised hosts such as HIV or chemotherapy, leukemia patients like that. Anybody who's getting cancer treatments and such, or have cystic fibrosis or some sort of inherent lung disease already, or very susceptible to pneumonias. So that'd be anybody who doesn't have a competent immune system. What do you do when you arrive on the scene? You got a sickle cell patient who's already auto-infarcted their spleen because of all the vaso-occlusive crises that they've been in, or the sickle cell patient who has had a splenectomy already, or the trauma patient from 15, 20 years ago who has had their spleen taken out because it ruptured in an accident or a fire or a gunshot wound, whatever it was, they've lost their spleen. These patients are also immunocompromised. They can look like you and me out there, except they got this big old scar on the left side. And you'll say, ooh, what's that from? Oh, I had my spleen taken out. I forgot to tell you. Surgical history is just as important in these patients, in the pneumonia patients, because a patient that loses their spleen loses the capability of what they call the reticuloendothelial system, which are cells that are produced to fight certain types of bacteria. And those bacteria, which are, by the way, responsible for most deaths, are bacteria that are surrounded with a slimy glycoprotein capsule. So when the white blood cell comes up to grab it and what they call phagocytosis, in other words, eat it and destroy it, it keeps slipping away. And so the pneumococcal, or the encapsulated bacteria, pneumococcal pneumonia being the most famous, when pneumococcal pneumonia start, within 48 hours, they've doubled, and another 48 hours, they've doubled again. If they've been at home for the last 2 or 3 days, you're already up against something that's 4 times bigger than what it was a couple of days ago. So you're going to be fairly aggressive with these patients as well. I know you don't carry antibiotics in the box, but just know this, that the patient's already immunocompromised because of loss of spleen, or they're on chemotherapy agents which suppress the immune system, or they're elderly, or they're patients who have caught the flu, a bad respiratory influenza A or B, like we just had recently, and then they put a pneumonia on top of it. And this has been the number one cause of death in the influenza patients, is a concomitant pneumonia, respiratory failure, and then death. All right, other factors that can predispose to it are alcoholism, asthma, COPD, sepsis, hypotension, fever, multi-level involvement, blah, 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 blah. In other words, everything. What you have to know for the National Registry exam, it's already very obvious, asthma and COPD, get it. Alcoholism. Watch the alcoholic. The patient that you pick up at home with 103 temperature, a 24 or 25-year-old guy who's been drinking and then aspirates, they get a peculiar type of bacteria called Klebsiella pneumonia, and it turns the lobe of their liver that the infection is in into a leathery substance. You can feel along at autopsy, and it feels like you're squeezing a piece of liver, a piece of leather, something hard. And this is supposed to be a nice spongy lung. So alcoholics tend to aspirate, and when they do, they can set up for this type of pneumonia. Also, as you know, or you may not know, alcoholism suppresses the immune system. And these patients have white blood cell counts to 1.9, 2.0, such like that, because they can't mount an infection because the alcohol has pretty much suppressed the entire immune system. Now, this is chronic alcoholism. Look, if you go out and have a couple of beers, I wouldn't quarantine yourself for 48 hours. That's not the way this kind of pneumonia works. Just watch for the chronic alcoholic. They're going to have a very peculiar type of community-acquired pneumonia, and they tend to be close to 100% mortality. So get them tubed early if you can, if they're showing any evidence of hypoxemia and such. Any of these immune-compromised people, you need to get a tube into if they're showing you any reason. Hypoxemia, tachypnea, the wheezing, the silent chest, pulse oximeters that can't get up again above 85%. Just don't slap an aerosol on them and say, hey, let's get them to the hospital real quick. You could get away with that, but it's a risk. And again, ketamine is your drug of choice here. Now, typical community-acquired pneumonia is strep pneumonia, which is called pneumococcal pneumonia. Could be Haemophilus, could be Catarrhalis. So you go into the emergency part, you go into an urgent care, and they say, yeah, you got a bronchitis, you got pneumonia, here's your Z-Pak, go home. Still the drug of choice. Zithromax is the drug of choice because it has a very long half-life. You take 5 days worth of Zithromax, and because of the half-life, it extends out over 9 to 10 days. It still has enough power or potential inside the bloodstream. It's a high enough level, even on day 9 and 10, that it's killing bacteria. So you take it for 5, but you get the effect of 10. And it's an interesting medication, Zithromax, in that it also heightens and stimulates the immune system at the same time. Most antibiotics just get in there and they start killing bacteria. Zithromax kills a bacteria, but it also stimulates what they call immunomodulation. It also stimulates the immune system to start killing bugs. So all of us within the emergency medicine community, board certified emergency medicine community, not the fly-by-night guys, but the actual boarded guys will put you on Zithromax as the drug of choice for community-acquired pneumonia, unless there's allergy or unless you failed treatment on it. Then they usually switch to Levaquin, Cipro, whatever. But for 95% of the cases, Zithromax. So you're going to ask your patient, hey, in the sample history, what medications are you on? And they're going to say, my doc's been treating me for a bronchitis that I had. I'm on Zithromax. What day are you on? I'm on day 1. Okay. I saw him 5 days ago, but I just got the prescription filled. Okay, another goodie. And then finally, the person who's been on it for 5 days just stopped yesterday. He's not showing any improvement. He's the worrisome guy. He's the one that's going to give you fits here, and could very well crash on you as well. So you're listening for tachypnea. You're going to hear rhonchi, and you're going to hear increased breath sounds, what we call bronchial breath sounds, which is adventitial sounds, which is just a real rough, coarse breathing. You can hear a person breathing from across the room. It sounds like a bunch of organ pipes. Rhonchi is a rattling, kind of a, you don't want to say death rattle, hey, he's got death rattles. Probably not a good thing to say in front of a patient, but it sounds like they're really rattling, and it's over a particular lobe, which is why we give you guys the 10 lobe stethoscope technique in the back, going from side to side, each side having 5 areas that you listen for. You're going to cover all the lobes. And there's quite a few lobes in each of the lungs. You learn upper, middle, and lower for the right, but when you break those up, it comes out to about 10 lobes. So, when you listen very carefully, and you're going to get agophony. Now, you don't have to write agophony down here. Just know it for your own self. You can things just sound different. There's a drum or an echo. I mean, it sounds like you're listening to something inside of a barrel. That's the agophony sounds that you can hear. Okay. Onward to pneumonia. The case that you'll have on the National Registry occurred in versions 2 and 3. Version 4 is out right now. But versions 2 and 3 had the pneumonia. Of course, I'm not privileged to have visibility on version 4 at this time. And of course, version 5 is still being developed. But 2 and 3 had the fevers, chills, tachypnea, tachycardia, generalized weakness, and productive cough, chest pain, or upper abdominal pain. These are the cardinal signs and symptoms of pneumonia. It may be in version 2, it was just a didactic question. In other words, blah, 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 of the following, which is not consistent with pneumonia. Well, if it's not on this list, and this is the actual list, if it's not on this list, then whatever that answer is that's not on this list is the answer. So fevers and chills definitely consistent with pneumonia, tachypnea, tachycardia. Now, the National Registry realizes that there's gray area. So they're not going to give you a borderline case. They're going to make it so obvious that you cannot refute or debate the question, the answer. The National Registry allows you to challenge a question, but I guarantee you the way that they're phrased, you'll lose, because there's a catchphrase in every single one of those questions, which makes it very, very clear what that diagnosis is going to be. And it's not equivocal. It's not a gray area. It's actually there. I gave a lecture a few weeks back about tips and strategies for taking the National Registry, and that was one of the tips. Is that be watching for that trigger statement that's going to sell the question and the diagnosis for you. So chest pain or upper abdominal pain, productive cough, anything that's colored coming out of the lung is going to be consistent with some type of pneumonitis. So the colors are green, yellow, green by itself, brown, or blood tinged. That just about covers it. The person who's bringing up thick white sputum may or may not have a bronchitis, may or may not have a pneumonia. But when they start getting into the rusty browns, the green, yellow, and such like that, you got yourself quite a pneumonia going on there. Now, you hook them up on a monitor, and there they are, tachypnea and tachycardia. You hook up a 75-year-old patient who's got COPD or asthma, and they come with tachypnea, tachycardia, and such like that, they have a higher risk for death. And this is usually the cause of death within the asthmatic COPDers and CHF patients, is the increased stress and strain on the heart that actually precipitates the MI. Subsequently, we like to get on these patients early. Airway management, we like to get on it real early. And of course, definitive airway management, in other words, intubation, the one and only definitive airway management is intubation, not the esophageal tubes, not the King tube, not some of the other Sangsteigen and Blakemore tubes and all the other stuff that's out there. Those are esophageal tubes that kind of indirectly go into the trachea and vocal cords. Definitive intubation, the tube passing through the cords into the trachea, is the definitive airway. Subsequently, when you see that phrase definitive airway in any scenario or any National Registry-based question, watch for definitive airway, and 2 words will be together in the same sentence. So that means intubation, or an answer is establish a definitive airway. They sometimes don't say intubate the patient. They'll say establish definitive airway. That's another test-taking tip. May or may not relate to your pneumonia patient, but if your patient's tachypnic, tachycardic, has generalized malaise, fatigue, and they're getting very tired from breathing, again, ketamine and then intubation. Now, for the patient you elect not to intubate, if they're having pleuritic pain, that's a pretty rough pain. That pneumonia is sitting close to the surface of the lung and it's rubbing up against the chest. It's like Velcro every time they take a deep breath or move around. So you want to give them a touch of morphine. Remember, you're paramedics. So don't buy into this garbage out there that, well, if I give him morphine, he's going to stop breathing. And guess what? If he stops breathing, you can handle it. you can tube patients. You're trained to do that. So you give a little medication and you watch the patient. 2 to 4 milligrams of morphine IV push. I've never heard of killing anybody or causing severe respiratory depression. Unless they're already in severe respiratory depression, you're probably already made the decision to tube them anyway. But don't be afraid of the definitive airway. If you bring in a patient who's intubated and we see that the patient's intubated, it's looked upon fairly favorably among real ER doctors, board certified ER docs. Again, not the fly-by-nights that are out there. Oh, what'd you tube them for? No, I got more work to do. Yeah, too bad, doc. That's why you're making what you're making. In our particular scenario, if you've intervened because you didn't like the way the patient looked, he was pale, tachypnic, tachycardic, diaphoretic, he's having pleuritic pain, guy's around 103 temperature, and looks like he was fatiguing, doc. I just had to put him to sleep. Take everything off his plate, except the patient's going to keep his heart beating. You will take over everything. You know what? We'll send you a gift. We'll buy lunch the next day. You save the person's life, you've intervened. It's the same thing with the National Registry exam. You're going to get these cases where you're going to have to establish a definitive airway if they're really getting fatigued. And in that statement, on the question, for the 4 questions that are there, they're going to say the patient is really running into respiratory distress, words to that effect. And so with the pneumonia patients, you could very well be tubing them. Now, let's say you don't. Again, back to the slide, you give them a little touch of morphine, 2 to 4 milligrams for the pain. You start giving them some IV fluids. He may be a little hypertensive, 190 over 100, give him the fluids. He may be hypotensive, really give him the fluids. Okay, don't wait for hypotension to set in. That's sepsis, and that mortality rate is incredibly high. Okay. Pulse oximetry, cardiac monitoring, oxygen supplementation, i.e., you can give these people aerosols. You can give them albuterol and Atrovent even if they don't have COPD or asthma. Why? Because not both sides of the lungs, both lungs on either side, front or back or lateral medial, you can't possibly have a pneumonia that's filling up both lungs. You can have one big whiteout, one lung and such like that. But if you've got a consolidation, a lobar pneumonia someplace where it's taking up a big patch right here, bronchodilation is going to open up the rest of the alveoli a little bit bigger. It's called recruitment. And what you do is you're going to recruit the rest of the alveoli, some that aren't used all the time that are up in the upper lobes, but you're going to take the normal ones and bronchodilate them a little bit, give this person an extra added benefit of having more oxygen provided to him, just with an albuterol aerosol with the Atrovent. And so none of us have any heartache with albuterol Atrovent with a pneumonia patient. They're having cough, congestion, shortness of breath. They're rattling, they're tachypnic, tachycardic, got a fever, bringing up sputum. Boom. There you have it. Okay, and then of course you want to position the patient in a semi-Fowler's position if possible to prevent any further problems, including aspiration.
Dr. Frame?
Yeah.
Dang had posted a question there saying, Dr. Frame, I assume he has a question for you. Dang, if you want to unmute your mic, you can ask.
Yeah, you guys should be unmuting your mics and asking, because when I got this on full share, I can't see the chat.
Dr. Frame?
Go for it.
So the patient who has pneumonia, chest pain is quite often shows. So is it imperative for us to do a total bleed just to make sure it's not heart related?
Dr. Frame, could you hear the question?
Here, Jane.
I could barely hear him, and now I can barely hear you too, so I don't know what just happened. Dang, can you ask the question again a little louder? Come closer to your microphone. Dang. Did you hear me? Can you ask the question again? Get a little closer to your microphone. He's typing it. He said, is it imperative to do 12 leads in these patients? Is there possibly a cardiac relation to the condition, or should they be looking for that, is where I'm assuming he's going, due to the chest pain?
Is it imperative to do 12 leads due to chest pain? Absolutely. The problem with pneumonia is that they can put a strain on the heart. And the pleuritic pain, which is a pretty reassuring pain, in other words, when you take a deep breath, it reproduces a sharp, non-radiating pain. It hurts right here kind of thing. Even though reassuring, could mask the achiness, pressure, tightness of a quiet MI, a background MI. So yes, it is imperative to do a 12-lead EKG on these patients. I wouldn't wait to do the 12-lead and then move the patient if you're pretty convinced it's pneumonia, but I'd certainly get a 12-lead en route. When you look at the fifth leading cause of death in this country is pneumonia, and the strain that it's put on the elderly patients usually die of cardiac arrest, secondary to respiratory failure because of pneumonia. So if you can get a heads up that you've got a patient with pneumonia that's having chest pain and he's showing MI, there's a good bet that the pneumonia put the strain on the heart, and whatever plaque was sitting in the artery because of the elevated blood pressure ruptured the plaque. And yes, you get a heart attack. Now, on the National Registry, and I'm not sure what the volume problem is here. Ashley, can you hear me any better? Repositioning the mic.
You sound really distant after you we interrupted you. I don't know what happened, but something made you sound like you're way away.
Let's try this.
That's better.
Okay. I apologize for that, folks. How much?
You guys hear me?
Yeah, it looks like it's been going on since 2030.
I just started when you went to this slide, after, when you were trying to answer Dang's question, or whenever he was asking, that's where it started.
Gotcha. All right. Dang, when it comes to the 12-lead EKG, yes, a pleuritic pain could mask a chest tightness or a heaviness. And subsequently, you have to do a 12-lead just to make sure that this pneumonia hasn't put a strain on the heart, which has caused either a plaque rupture or actually thrown the patient in some sort of tachyarrhythmia, which then led to or an MI or perhaps a cardiac arrest, although I'm pretty certain you'd recognize the cardiac arrest right away. But yes, short answer to your question, is it imperative to do 12 leads on a pneumonia patient? Yes, it is. If you got your hands full, and let's talk about real world, no kidding life, when you're a paramedic in the field and you've got your hands full with the patient, they're really showing a lot of shortness of breath and difficulty to breathe, and you're making a decision, you're drawing up ketamine, you're making a decision whether or not you intubate this patient, so you're holding the tube and laryngoscope in your hand, you're watching the patient. I wouldn't really expect you to get a 12 lead at that point, especially if you're the only person in the back. You're watching really for the respiratory failure that's about to happen. And remember, when you think intubation, you should probably do intubation. So I hope that answers your question. I can only, let's see. All right, much better already. Sounds very fun. Okay. Ashley, can you hear me now? Okay. All right, so it's probably something at my end. I'm not sure. Maybe flipping the slides on and off the way that I did reset something. I'm not sure, but let's keep going. And it could also be my headphones. Even though they're Bose, there may be something wrong with that. I'll check it all out. So I apologize, folks. So anyway, treatment for pneumonia on the scene. 3 doses, 1 continuous, 1 hour continuous albuterol aerosol. So that's 3 doses into the reservoir, 6 liters on the mask, go any more than that, you're just blowing the stuff all over the place. 6 liters gets into the reservoir and causes a nice maximum production of vapor of the albuterol. So don't feel like you got to spin that non-rebreather up to 15 liters and then pop that asthma vent onto the mask and let them breathe it, which is a heck of a lot better than holding the mouthpiece if they're in this much distress. Let them breathe it in through their nose and their mouth. The whole vapor is hitting them in the face, but no more than 6 liters into those aerosols. Studies have shown maximum vapor production with 6 liters. Okay, let's see now. I can see the chats now at the same time. So this is a good thing. So if you have any more questions, I can at least see them now. Okay, suctioning. Always be aware of that, because whatever they're putting down there, whatever they're coughing up, they're probably aspirating as well. I like CPAP right away. And that's a very good question, Denver. Of course, I wouldn't expect any less from you after I've looked at some of your grades and such. You're pretty impressive guy. Anyway, Denver, it's a good question. When do I prefer CPAP over ET? You know, it's like sending in SEAL Team 6 for a parking ticket, you know, for law enforcement. I mean, I think I want to tell you that CPAP going into a patient who's having this much respiratory distress may seem like overkill, but in actuality, it's not. And it takes a lot of strain off the heart, because when you increase intrathoracic pressure, you're pushing any pulmonary edema that might be coming in. You can't push it back into the bloodstream, but you can prevent any further water from coming in. But it also reduces preload coming into the chest. That makes it a little bit easier on the heart. And so CPAP in somebody who's struggling, go ahead and do it. Just remember that there are clear indications for CPAP and there are clear contraindications for CPAP. And if a patient does not have a gag, lethargic, or in any way showing you altered mental status, or an unstable chest, an unstable situation, you're going to have to go to the ET tube. Patient's alert and awake, got a gag reflex, but really struggling, but can follow commands, go ahead and start the CPAP. Good question. Okay. Any questions about pneumonia? All right, very good. Let's see, would you try epi, corticosteroid, CPAP? If that doesn't work, go to intubation, more for asthma. You know, I throw anything that I can at these patients. I'd be a little bit reluctant to epinephrine in somebody who's over age 50 or somebody with documented cardiac disease. Epinephrine being both an alpha and a beta stimulator could whip up that heart pretty hard. If you got a patient who's already tachycardic, 140, 150 and such, I'd probably hold off on the epi. But corticosteroids, which you know aren't going to work for a couple hours, CPAP would be my first choice, especially for you guys and girls in the field. I'd throw CPAP on these patients right away. Just remember that the treatment of choice is 3 doses of albuterol with atropine in a mask at 6 liters, mask. And you'll want to give them that treatment over 1 hour. 6 liters for 3 doses will vaporize over 1 hour. If your patient is starting to struggle and you have to put them on CPAP, you've lost the advantage of an albuterol aerosol. If your CPAP mask can accommodate an aerosol at the same time delivering CPAP, by all means do it. But if you don't, weigh very carefully what you're trying to accomplish here. CPAP for an asthmatic, CPAP for a CHFer, yes. CPAP for a toxic irritant such as chlorine ammonia that we talked about earlier, yes. But watch it with the asthmatic. If you put a patient on CPAP, you're also reaching for your med box, getting the ketamine and the ET tube out. Racemic epi. Possibly. Younger patients, definitely. Children, absolutely. If the albuterol aerosol attachment isn't working for the children, you can put a racemic epi in. If your child is croupy and very stridorous and looks like they're bad shape, yes, racemic epinephrine. Occasionally, you get an adult with epiglottitis, and racemic epinephrine work for that too. Now, I don't encourage you looking in a person's throat to see if they got epiglottitis. Just remotely touching the epiglottis as it comes up into your airway vision there can cause it to swell instantaneously, and now you got yourself a tracheostomy concern or a cricothyrotomy concern. In pneumonia, asthma, or both? Both. Absolutely. Your objective isn't so much to open up the airways that have been involved in pneumonia. Hell, that's already happened. You want to open up the other airways that have not been affected and maximize their ability to handle oxygen coming in and then delivering it to the bloodstream. So yes, that would make perfect sense in that situation. But remember, when you're talking about racemic epinephrine or epinephrine in general, or inhaled epinephrine, whatever you're talking about that's outside of albuterol and Atrovent, you're talking about a patient who's really crashing. So you better be justified in your use of epinephrine, especially in the older patient. Now, as far as magnesium sulfate, clearly it's the standard of care. Magnesium sulfate's been shown to assist in bronchodilation. I'll give mag sulfate to any asthmatic that comes in where I'm standing at the bedside with a tube in my hand. I'll ask for the nurses to put 2 grams up and start infusing it, but at the same time pulling ketamine and such. So a patient arrives in my emergency room, let's say they haven't talked to one of your good folks and they're in status asthmaticus, or they're having pneumonia and they're 103 temperature and they're really crashing on me. They'll get the albuterol aerosols while we are setting up. We'll get the IV in, we'll get the corticosteroids in, Cimetidrol 125 being a standard. Sometimes I'll go with 250 just to kind of increase its efficacy a little bit quicker. And then hang the magnesium sulfate. But all the time, knowing that once I start making a decision about magnesium sulfate, CPAP, some of the other more advanced therapies out there, that I'm really thinking about tubing the patient. So good questions about the magnesium sulfate. It is standard of care. Okay, let's move on to toxic inhalations. We may make this a 3-part episode. As a matter of fact, we've been online for 57 minutes. Some of us horsing around trying to fix this damn thing, but I'm not going to keep you longer than the 1 hour. So this will now be a 3-part respiratory emergency, and I have Thursday night off. And so I would like to pick this up pretty quickly. So today's Tuesday, I'll be off Wednesday. Let's rejoin me at 8 o'clock on Thursday, and we'll finish out pulmonary embolisms, toxic inhalations, and all the other happy stuff that you're going to run into that I have seen on the National Registry. Just keep in mind, anything that I deliver to you right now is based on my review of questions, versions 1, 2, and 3 with the National Registry. And these slides are generated right from those tests. All right, let's see what we got. Sounds good, works for me. 8 p.m. on Thursday, see you there. All right, Jane, you still there?
Of course.
All righty, Thursday night, 8 p.m., it's a date.
All right, honey, I'll set it up. I will go ahead and post the link on the news feed and send it out. That way everyone will know that we've got a last-minute edition. And then we also have Dr. Eschelbach on Monday night at the same time, and I have no idea what his topic is.
Will, thank you for being here. All you guys, thank you for being here. We'll cover part 3. Part 3 is going to cover the last 2 questions on environmental respiratory emergencies and the biggie, pulmonary embolism. The number 2 cause of sudden death in patients is pulmonary embolism. Not everybody dies of a heart attack, folks. All right, see you on Thursday.